Welcome to the Spinal Cord Injury Forum. The Spinal Cord Injury Forum is a product of the Northwest Regional Spinal Cord Injury System, which is funded by the National Institute on Disability and Rehabilitation Research. And today we are extremely pleased and excited to have our keynote speaker, Dr. Dan Lammertse, coming to speak today about spinal cord injury research and the hope for cure. Where are we today? Dr. Lammertse is a clinical professor with the University of Colorado and serves as the medical director of research for Craig Hospital. He is co-director of the Rocky Mountain Regional Spinal Cord Injury System. He has served in many capacities for the American Spinal Injury Association, which is really a very elite spinal cord injury system, or I should say an organization, and he served both on the board of directors and as past president as well. In 2012, I was in Denver when he was honored in his own hometown with a Lifetime Achievement Award to recognize his contributions to spinal cord injury care. He has been a research collaborator in spinal cord injury clinical trials, an advocate for inclusion in inclusive research for people with spinal cord injury, and I've really heard him speak in defense of the need for very consistent scientific rigor in the way that we conduct, report, and evaluate different scientific data on spinal cord injury cure. So I'm very, very excited to have him speaking today. So I'll turn this over to Dr. Lammertse.
Okay, I'm really happy to be here. I'd like to thank the organizers and specifically Dr. Reyes and Dr. Bombardier and all the folks at the university for inviting me to come. This is a topic that is dear to my heart. It has really been my professional passion for over 30 years. And might just start by telling you a little bit about my background. I finished my training a little over 30 years ago and in rehabilitation medicine, and I had a specific interest in spinal cord injury. This was to be my career path. I never really thought that I would get involved in clinical research when I started out, but I faced some hard questions from patients and families, folks like yourselves, about why we couldn't help people actually have recovery of function, why we couldn't improve recovery of function. And some of you that have heard me speak before may have heard me relay this story, but I kind of got started on this path by a family who came to me in about 1982 with a simple question. If we can put a man on the moon, why can't we help my daughter to walk? And I suspect that some of you have had a similar question that popped into your mind when you were facing for the first time the unwelcome and unanticipated and sudden catastrophic change in life circumstance that is spinal cord injury. Well, that simple question launched me on a search to find an answer. I was young enough and naive enough at the time that I didn't just blow it off as, well, that's kind of an odd question, and of course we can't make someone get better. So I hit the books. In those days we didn't have the internet. I went to the library stack, started pouring through articles and research, and I came to the conclusion, and this is back now over 30 years ago, that there was a glimmer of hope that I had never been exposed to as a trainee in medical school or in my residency. And that I felt that this was something that, an envelope that we needed to collectively push, if you will, to try to help folks have a better neurologic recovery, to expand the horizons of what we do in rehabilitation beyond the critically important and profound mission that we had of teaching people how to be more independent and to do transfers and to do what they can with the recovery that they've had experienced, but that we need to expand beyond that and to be thinking in a broader context about helping to improve the recovery that is happening and happens in most patients, that we could improve recovery and hopefully have folks be less disabled by virtue of scientific discovery. So I sort of wandered off into a part-time clinician, part-time research career, and for the last 5 or 6 years I've been purely a research physician As was mentioned, I've had the privilege to be involved in many clinical trials over the past 30 years, and in the past 10 or 15 years have had the opportunity to be involved in some of the trials that you may have heard of in terms of cell-based therapy trials and other drug trials. So I come to this talk with some degree of experience, and I'd also have to humbly admit to you, like I suppose most scientists, I'm still learning, and we still have a lot to learn, but at least I can come to you with some sense of hope and vision for where we have been and where we're headed. So, 30 years ago, when I got started into this, you could arguably say that we were just entering the era of clinical trials in spinal cord injury. We were seeing the advent of important drug trials, the NASCUS trials, which some of which were done in part here in Seattle, that kind of set the stage in terms of what the standard would be, how we should conduct clinical research to try to find important answers for people with spinal cord injuries. And yet, in spite of some presumed successes and failures and a lot of hard work, we still do not have an FDA-approved treatment for improving neurological function. And in fact, I would submit that we don't really even have a consensus standard of care. In other words, if you were to line up medical spinal cord injury physicians and surgical spinal cord injury clinicians and ask them, do we have a clearly defined standard of care of how to preserve neurologic function and improve neurologic function? The answer is, well, we've got some good ideas, but the scientific evidence basis for saying it's good enough, that it ought to be a standard of care, that it's given to every single patient, we're not there yet after 30 years of trying. We're coming closer, but we're not quite there yet. And we need to do better, obviously. So my agenda today is to give you a little bit of a background about what happens to the spinal cord injury after trauma. What is the pathology of spinal cord injury? Why doesn't the natural healing process that is set in motion in every patient reliably produce a recovery of function? Why does it seem as though the spinal cord, in its response to injury, is different than most other organ systems of the body? I mean, we've all been injured in one form or another. We've had lacerations or broken bones or had other traumatic events. And in most of those circumstances, the recovery, the healing process that is set in motion produces a recovery of function. And while I'm going to tell you that most patients with spinal cord injuries have some recovery, unfortunately, natural recovery is typically not enough. So we're going to go over what do we know about natural recovery, what are the opportunities for scientific intervention, what is the evidence basis for determining the effectiveness and safety of a new treatment. I give a monthly lecture to our patients at Craig Hospital about this overall general topic, and I found over the years that one of the critical components of that lecture in terms of just creating an understanding that would yield a productive dialogue is that we need to really think a little bit about what is the nature of scientific evidence. And we're going to go into a little bit of that. What is the process for regulatory approval? I think this is an important question, and it may seem kind of ho-hum and mundane to some of you, but one of the issues that we face is how do we get something approved so that it can be given to all patients rather than simply people participating in a clinical trial or research protocol? What would it take to actually get a good idea, enough of an evidence basis for the FDA to say, okay, you can go ahead and put that on the market, we can give it to every patient, and we're no longer in a research mode. Where are we today? And then at the very end, I'm going to gaze into the crystal ball here and give you at least some of my ideas about where we're headed. Okay? So, this is going to be a 35,000-foot view. I'm going to try my best to avoid a whole lot of graphs and data, and as some of my scientific colleagues say, I'm not going to do a data dump here. we're going to be taking a broad view, and I'm going to give you my more of an impressionistic assessment of where we've been, where we are, and where we're headed. And I'm going to choose my words carefully. This gentleman is saying, I regret my poor choice of words, that my poor choice of words caused some people to understand what I was saying. This is obviously a cartoon that appeared in the New Yorker during the last presidential election when we had a lot of obfuscation, to use a word that this guy probably would have tried to use maybe. But I'm going to try to not use a lot of fancy medical terminology, and if I do, I will hopefully preface or whatever, elaborate that with something that's understandable so that this isn't going to be just a dry scientific talk. Some background. Why is this research necessary? And this gets to the critical question of why people don't get better enough all too frequently after spinal cord injury, even though most people do get some better. Well, for one thing, this is a very complex pathology. Most people that have spinal cord injuries have had a contusion to their spinal cord, and as you can see, with my, there we go, this is a section of the spine. Here's the spinal cord, here's the bones, and what you can see here is the site of trauma, and that produces an explosion of bone fragments. The spine is a very resilient and strong structural element of the body. It takes a lot of force, or the happenstance of enough force applied over a big enough lever arm with enough mechanical advantage, if you will, to explode that bone. And when that happens, that bone is propelled back into the spinal cord and punches or pinches it. And a couple of things happen when that occurs. Number one, the patient, at the moment of impact, typically will tell us that they lost sensory and motor function right now, or over a period of seconds. This was an immediate event, in other words, that caused the loss of function. But that's not the end of the story. And in fact, when I was in medical school, we were kind of taught that, well, the text of this drama was written at that moment of impact. We didn't know the end of the story at that point, but there wasn't anything we could do. That die was cast immediately at that moment of impact. But now we know it's not quite that simple. Now we know that beyond that immediate loss of function that happens after the impact, that there is a secondary injury that really gets momentum within the first 4 to 8 hours of the injury and continues for several days. This is the result of a very complex, and I threw this up here not so that I want you all to read it and understand it, but just to point out the complexity of this pathology. And it really is the byproduct of ischemia, which is the fancy medical word meaning loss of blood supply. Loss of blood supply to critically injured tissue. And that sets off a biochemical chain reaction. And that chain reaction is different in the central nervous system than it is in the rest of the body. And that's one of the problems that we have in trying to design treatments for spinal cord injury. It's probably one of the primary explanations why the spinal cord and the brain, for that matter, the central nervous system, respond to injury in a less predictable and less satisfactory way than injuries to the rest of the body, to a broken bone or a bruised muscle, if you will. And in fact, some of you might have been thinking, well, this is a contusion, which is the medical term for a bruise. That sounds like a trivial injury. But unfortunately, it is not in the central nervous system. A bruise in the central nervous system commonly produces lasting, significant impairment. The ability for the central nervous system to recover from a bruise is not at all like the bruises that we commonly think of. I would hazard a guess that most of us have had thousands of bruises in our lifetimes, and we probably don't even remember the last one we had, because bruises are trivial injuries most places in the body but not in the spinal cord. There's also a healing process that's set in motion. This is a natural response to injury, and it happens everywhere in the body in response to injury, but that healing response in spinal cord injury has some unique features that we need to understand. Number one is that some of those nerves that are coursing up and down the spinal cord, the neurons if you will, are disconnected. The long process that we call the axon, which is that process that is kind of functionally the wire of the nervous system that conducts the impulses, like a wire conducting an electrical impulse. That axon is typically disconnected, either because of the primary injury or because of the effects of the secondary injury. There's an initial attempt, even in adult humans, like most of us. We're all mostly adult humans, I think. Even in us, this kind of an injury would produce an initial attempt at regeneration. But within several weeks or so, that regenerative process grinds to a halt prematurely before it has achieved its mission, which is to get hooked up again and to recover function. This has been called abortive regeneration because it stops prematurely. There's limited repair, some ability to repair, but it's limited. There's also a phenomenon called sprouting or plasticity, meaning that the surviving neurons react to this injury and start to send out other processes to recapture and to reestablish connections with other surviving neurons. They sprout like the branches on a tree to try to interconnect and to rebuild circuitry, if you will. And this is called plasticity. It's the ability of the nervous system to change and to morph into something new in response to injury, to try to develop new circuits or to rebuild previous circuits. But unfortunately, that isn't very successful. There's also the formation of a glial scar. And unfortunately, if you were to just look at the big picture of the cellular environment at the site of injury, what you would see is that by and large, nerve elements, and nerves are the active cell in the nervous system, if you will, have been largely replaced by glial scar tissue, scar cells. And unfortunately, those cells don't conduct nerve impulses. They have a critical role to play in how the nervous system works, but they don't conduct nerve impulses. And so what we've had is a replacement of a lot of the nerve cells with cells that don't subserve the function of the nervous system. And lastly, there's this process called apoptosis, which is genetically programmed cell death. So even weeks or months after the injury, there's kind of a use it or lose it phenomenon, that the cells that have been disconnected and no longer are conducting signals start to say, okay, well, we're not really needed anymore, we'll drop out. And those cells basically commit suicide. And some of those cells are lost even weeks after the injury. Okay? But most patients have some functional recovery, but in most patients. I don't know that I've ever met a patient who had even a lot of recovery who felt that it was enough. We all want more. We all want to be back as close as possible to our functional status prior to injury. So that even though most patients get some recovery, it's typically not enough. Now when I was in training again, I was kind of left with this impression that this inability for adequate recovery after a spinal cord injury was a law of nature. It was not worthy of scientific pursuit or discovery because this was just a pronouncement from on high and we shouldn't argue with laws of nature. We shouldn't try to bend them or change them. Well, as I went to the library back in 1982, it became apparent that that wasn't the case. This was not a law of nature. In fact, fishes and certain species of amphibians do have the potential to recover after injuries like this. Fetal mammals have the ability to produce significant functional regeneration. The peripheral nervous system in all of us has the potential to regenerate. So we can't say that this is a law of the nervous system. There's portions of the nervous system that regenerate pretty well. Maybe not perfectly, but this is the reason, an example, it's reasonable to do surgery for carpal tunnel syndrome. This is the reason why it makes sense to reattach a severed limb. Every now and then you'll read about somebody that was in a farm accident and got their arm taken off in a terrible accident, and they put the arm in ice, rush them to the hospital, put the arm back together, and a surgeon, a good surgeon with a lot of skill, looks at the nerves and the blood vessels and muscles and bones and puts them all back together under a microscope. And sometimes you'll also, and that gets into the newspaper, if you're lucky, maybe 6 or 7, 8, 9 months later, there'll be a follow-up story. And they'll say, well, that hand is starting to move. The sensation is starting to come back to that hand. Those nerves will regenerate. They grow at about 1 millimeter a day, so it doesn't just happen immediately, but there is the potential of peripheral nerves to regenerate, which also tells us that this is not an absolute law of nature. Other clues. Well, we know that abortive regeneration was described over 100 years ago by Ramon y Cajal. He was the first recipient of the Nobel Prize for Medicine and Physiology. He took as his task to try to understand the response to injury of mammals and other species. And specifically, he was the first one to discover that this regenerative process in people that have spinal cord injuries gets started but then stops prematurely. So there might be something that we could learn about how it got started and why it stopped that would be an opportunity for treatment. There's also been a discovery of growth factors. This also led to a Nobel Prize. These are chemicals that promote the growth, promote regeneration, make regeneration happen more vigorously. They also support the metabolic functioning and the health of cells that are under trauma stress. So growth factors have been an important other discovery. Inhibitory factors. All biological systems work on a basis of homeostasis. If there's something that promotes, the scientists always go looking for its counterpart, the mirror image, that factor that would inhibit. So we think of biological functioning as a delicate balance between promotion and inhibition. And it's those events or factors or things that sort of tip that balance in one direction or another that are actually the determinants of whether or not a biological process happens. In this case, regeneration versus not regeneration. It's one of those delicate balances. It tips between promotion and inhibition. There have been the discovery of inhibitory molecules, in other words, that are kind of the counterpart, the opposite of the growth factors. In addition, there's been some attempts to understand why, after patients have been injured for a while, those connections that have been made and the recovery that occurs sort of plateaus and doesn't get a whole lot better beyond that. Why is there a distinction between the receptivity, if you will, of an acutely injured patient, or a patient that's only been injured for months, a few months, compared to a patient that's been injured for years? And it turns out that there is this establishment of what's called the perineural net, which is kind of the scaffolding, if you will, upon which the nervous system circuits are formed. And it surrounds the nerves and creates some inflexibility, if you will, for the creation of new circuits and new connections. And that may also be something that we could take advantage of if we understood it better in terms of unlocking the potential to apply a lot of the acute treatments into chronic patients. By the way, in my lecture to my patients at Greg, and I throw up the big table of trials, sometimes the patients say, well, you know, a lot of these don't apply to me. And my response to them is, well, they probably all do in some way or another, because there is this question of if we could unlock the rigidity of the connections in the chronic state, we could apply some of these earlier phase treatments to more chronic patients. So I look at it as a continuum that has applicability to all patients. So What about natural recovery? What do we know about the natural prognosis, if you will, for patients to improve? What we can say is that if you picked a function, let's just say it was the wrist extensor in a C5 or C6 tetraplegic, or maybe it was the elbow extensor in a C6 or C7 tetraplegic. If you mapped out the function of that specific activity, you could apply this concept, by the way, not just to muscles, but also to sensory function or to other functional activities. But what you would see is that there is an initial improvement, but then over time it tends to plateau out. And those of you that have been injured for a while can relate to this, because you probably remember that during rehab, during the first 3, 4, 5 months, and once you got into outpatient, that you were still changing and getting better. But that once you got out to about a year or two, that improvement, the increments of change started to get smaller and smaller and smaller. And in fact, those of us that try to measure these things find that once you get out to about a year and beyond, year and a half, 2 years, that those increments of change are small enough that they're beneath the resolution of our measurement. We can't really detect change once we get out that far. Even though many patients are still telling us that they're changing, but the magnitude of that change over time starts to drop off. So it's called a plateau effect. We also know that if you looked, and now this is in reference, to, as an example, a muscle at the level of injury. But even if we were to look at the likelihood of the severity of the injury improving to the extent that the long tracts, the long nerve tracts that are coursing up and down the spinal cord are starting to get better. That would be to go from complete injury to an incomplete injury. But that also happens and plays itself out over time. As an example, this is just looking at data from a collection of the big databases that have looked at patient recovery. I think most of you are probably familiar with the terminology ASIA Impairment Scale A, ASIA Impairment Scale B. It's a description of how incomplete the injury is, how much sparing there is of tracts that go down to the lower extremities, as an example. If we looked at the ASIA Impairment Scale conversions from A, which is a complete injury, to better than A, and this is a scale that goes from A to E, you'd see that about 20% in these big databases, and the 3 databases they looked at was the Model Systems database that you folks here in Seattle are contributing to, the SCI database. This was the largest human experiment ever conducted in spinal cord injury, enrolled almost 600 or 700 patients. I mean, a big trial of a drug called SCI back in the 1990s. And this is the European Multi-Center Spinal Cord Injury Study. It's a big database that's maintained in Europe. What you can see is that about 20 to 25% of the patients who are complete injuries within the first week or so wind up converting to being incomplete. And you can see that that even extends to some of those patients that become ASIA D, which is most of those patients are going to be able to walk. If you were to look at those that started as ASIA B, this is the people who have sensation but can't move their legs. They have sensation of their legs, basically. You can see that there's quite a few of them that improve to C and D, which is motor incomplete. If you were to look at the ASIA Cs, these are the folks that have some motor function in their legs, but it's not usually good enough to walk with, that most of those patients, the vast majority of those patients, improve to D. The Ds tend to stay Ds, but that's because they have what we call a ceiling effect. That's a very broad category, and although most of those patients will get quite a bit of improvement, with the way the classification is stated, if you will, or designed, we really can't measure the change. But these patients are also getting quite a bit better, the Ds. So, what do we need to improve upon? I've already said that most spinal cord injured patients experience improvement over that first 12 to 18 months. 70% of all patients with a cervical injury will descend 1 level. 30% will descend 2 or more levels. And the therapists and physicians in the room know that this is kind of one of those standard concepts that everyone appreciates who takes care of patients, that a single level of improvement can make an enormous difference in the amount of functional capacity that the patient has. It could be the difference between able to drive an adapted vehicle and not, to be able to use a manual chair as opposed to a power chair, to be able to do a transfer independently or dressing activities, that sort of thing. So one level of change can be huge. 2 levels of change is even better. So this is a fairly common occurrence in terms of natural recovery. 20 to 25% of the ASIA A patients, these are the motor sensory completes, will become incomplete. That's from the graphs that I showed you in the previous slide. 8 to 10% of those initial ASIA A's will improve to C or D. These are the patients that have motor recovery in their legs. And even chronic spinal cord injury can change. There was an article that was published using the national database back in 2004 that showed even patients who were still examining as a complete injury at the end of a year, that a percentage of those patients, 3.5%, improved to incomplete, and that 2%, a little over 2% of those patients at 1 year improved to C or D. So we can say that even the chronic patients have some potential to change. Again, the increments of change get very small in general, but we can say that some of those patients are going to get better even way out in time. And 20% improved a motor level and neurologic level of injury between 1 and 5 years. That's huge. That's a lot of patients, especially in the cervical level, that are going to have a significant functional improvement more than a year out. So, what are the opportunities for intervention? Well, number one, remember that secondary damage that really gets rolling within a few hours of the injury and lasts for a couple of days. Patient's already paralyzed, but not all the damage has occurred. So the concept here is, if we could limit that secondary damage, if we can intervene early enough, then that would form the basis for a better recovery. We'd have less tissue damage. That's called neuroprotection. We could also promote regeneration. We could reawaken that latent potential that was exhibited early on, but then sort of ground to a halt after the first couple of weeks. We could perhaps find a way to use these growth factors that have been discovered, or more likely, chemicals that mimic the effects of growth factors. Okay? Growth factor itself, the classic chemical that resulted in the Nobel Prize, is a pretty dangerous drug. In fact, it probably can never be used in a human because it has too many bad side effects. But researchers are hard at work trying to find drugs that mimic the good effects of nerve growth factor but don't have some of the bad downside effects. And we're going to talk about a trial briefly that is doing just that, or investigating that. We could also suppress inhibitory factors. If this balance is a critical issue, we can either prop up the good side or we can suppress the bad side. So we can suppress inhibitory factors, and maybe that would open up a new opportunity for some regeneration. We could also improve on the repair side of things. A lot of the nerves that are in the spinal cord and run past the area of the injury are not literally disconnected. Some of those nerves have lost their insulating sheath. That's called the myelin sheath. Okay? And when that happens, it causes enough of a problem in the nerve conduction that the impulse that's traveling down that nerve kind of gets blocked right where the myelin sheath has been destroyed or has been damaged. And so some of the therapies that are currently under investigation have as their target mechanism to remyelinate some of those nerves that have lost their myelin sheath. We could also replace dead cells. I have to tell you that when someone has a spinal cord injury, there are typically hundreds of thousands, perhaps even millions of cells that succumb right in the area of the injury. The fact of the matter is, the spinal cord injury is pretty healthy above and below the injury, but there's about a 1-inch segment of the spinal cord that is severely damaged. And in that segment of injury, there's a lot of cells that have died. And it's true that, by and large, Mother Nature has not designed a plan to replace those dead cells. This is not true in other organ systems in the body. As an example, The skin you're all wearing today, probably only about a month old. Because we're all making new skin cells, and the old skin cells sort of migrate to the top and they come off, and we call it dandruff if it's in your scalp. But we're making new cells all the time. That does not happen in the central nervous system. Now I'm going to have to put a small asterisk on that statement, because now we know that there are stem cells that are sort of hiding out all over our body, and in response to injury, it is plausible that a few of those quote-unquote adult stem cells could be transformed into a nerve cell in response. But the problem is, even if that does occur, it doesn't appear to be a major contributor to the recovery process. So the way we could address these dead cells is to put new cells into the system, to implant cellular therapy, if you will. Okay? We'll come back to that. We could also promote sprouting and plasticity. This would be if we could enhance the cellular environment, drugs or cells. Or, and the therapists in the audience are going to love this, because we now understand that there is the potential that rehabilitation itself, unlike what we were taught 30 years ago, which was we can't affect the recovery. All we can do is teach people how to do transfers and to get dressed and to feed themselves and to do things by compensating for their loss with the learning of physical skills or physical skill acquisition. Now we know that there is the potential that rehabilitation, if applied at the proper timing, with the proper intensity, the right activities, can actually promote some of this plasticity. We can mold recovery, if you will, in a more positive direction. So that is also in the mix. So, some concepts and examples. We've already mentioned drugs and molecules. There are a number of trials that we're going to just go through a few examples. This is not meant to be an encyclopedic review of all the trials that are currently underway. But there's a trial that's being sponsored by a Japanese drug company called Asubio Pharmaceuticals that is actually giving a drug intravenously to patients, and it started soon after the injury, within 12 hours or so, and it's intended for neuroprotection. That process that we talked about that intervenes before the secondary damage kind of gains momentum. It's a drug called SUN13837. These experimental drugs are all given vague alphanumeric names. They don't really mean anything. They'll probably find a catchy name to give this if it ever gets out of FDA approval process. But we could also suppress inhibition. Remember, we talked about these inhibitory factors. Well, one of them has been identified, and it's called no-go. Kind of a common sense name for a protein that stops the nerves from going where they want to go. It stops regeneration. So this is called no-go, and some bright scientists figured out a way to develop an antibody that sort of takes the no-go protein out of circulation. So it suppresses the inhibition. This actually was tested and is in trials right now. It was tested in a phase 1 trial in Europe. The drug is called ATI-355. That's a drug that is under license by Novartis Pharmaceuticals, which is the largest drug company in the world, basically. It's based in Switzerland. They have completed a phase 1 trial with about 50 patients enrolled in Europe and are now in the process of figuring out how to move to the next phase, to phase 2. And we'll talk about the phases in a little bit here. We could also use some drugs that have been shown to be neuroprotective because of the way they block ion channels. Remember that really complicated thing with all the arrows and boxes? If we'd had a blown up version of that, you would see that some of those boxes were describing the flow of ions, like sodium ions and calcium ions and whatever, in and out of the cell. And that's part of the pathophysiology. That's part of the damage, the biochemical chain reaction, if you will, that's going on. And we could use some drugs that would block some of those channels and that would be neuroprotective. They would prevent some of the membrane damage, if you will, by interfering with some of that flow of ions across the membrane. We could also find some drugs that might act physiologically. In other words, help the nerve. Remember we talked about that demyelinated segment? and how the nerve impulse got blocked when it hit the sort of the stripped off part of the myelin. Fampridine SR is a drug that kind of helps some of those nerve impulses actually make it across that gap where the myelin is missing. And so a drug like fampridine might also be effective. In fact, there was a series of trials in spinal cord injury back in the early 2000s that were looking at fampridine, and a number of centers, including University of Washington and our center at Craig Hospital, were involved in those fampridine trials. We had a lot of hope for that drug, and it seemed as though some of our patients, even those of us who randomized placebo-controlled trials, so we really didn't know who got the drug, but we had this impression it was helping. Unfortunately, when we broke the code and tried to figure out who got what and what they did, we couldn't prove that it was beneficial. The drug company, however, said, well, we're not done with this drug. Spinal cord injury is kind of hard to study, but we still have hope for it. We'll try it in multiple sclerosis, which is a disease that causes demyelinization, okay? And they got the drug approved because it helped MS patients walk better, okay? Now they're talking about whether or not they can revisit studying spinal cord injury with this drug and seeing if we could figure out a way to get it approved for spinal cord injury as well. Cell-based therapies. Schwann cells. Schwann cells are the cells that produce the myelin sheath in the peripheral nerve, which is a part of the nervous system that does regenerate. So if the concept is we want to create a beneficial cellular environment here, maybe these nerves would help us achieve that. There have been 40 years of vigorous attempts to find animal model, preclinical research to support going to human trial, and it finally bore fruit just towards the end of last year when the University of Miami got the approval from the FDA to begin an experiment. This is not to say it's FDA approved, but they approved going into a human trial. So at the University of Miami, they've now enrolled 2 patients in a trial to look at whether or not Schwann cell implants into a patient would be beneficial. Stem cells, human embryonic stem cells, and the cells that are processed from those, specifically a cell called GRNOPC1, again one of those alphanumeric names. This was the GIRON trial. It got started about 3 years ago or so, 3 or 4 years ago, and unfortunately stopped prematurely because of financial reasons. The good news is, and by the way, they'd already enrolled 5 patients in that trial. This was a phase 1, first go-around trial. But now another company has bought up the research portfolio and is looking for ways to start up a new trial with using these cells in spinal cord injury. So we're all very hopeful about that. Neural stem cells. There's now a trial going on in Switzerland sponsored by Stem Cells Incorporated, which is a biotech company in the Bay Area in California. And that trial's up and running. They've already enrolled about 4 or 5 patients in a phase 1-2 trial to try to show whether or not these cells can help recovery in chronic spinal cord injury. Those patients have to be at least 3 or 4 months past injury, and they have to be neurologically stable. Neural Stem is another company that is in the process of starting up a trial. They've had a lot of dialogue with the FDA. They're essentially about ready to go, but they haven't started enrolling patients yet, but will soon. Bone marrow-derived mesenchymal stem cells, that's MSC, that just says that these cells are found in the bone marrow and they're part of the cell categorization that we call mesenchymal cells, or basically structural cells in the body. And there are many examples. By the way, I think most of you got a handout that's a big table of all the trials of restorative research that are currently underway. And there is one column in that table that describes what the intervention is, and you're going to see a lot of mesenchymal stem cells trials that are listed there, as well as umbilical cord cells. And this is a trial that's been underway for a while now, a series of trials in China that have been under the auspices of the China SCI Net trial system. So, the basis of evidence. Now, if we could use some of these, how would we determine whether or not they had an effect? That's the question. Building the case for efficacy. There are a lot of variables that we have to consider when we're trying to figure out why did a patient get better. We know that most patients do get better, so natural recovery has to be fit into this equation somehow or other. There are aspects of clinical care that also presumably might have an effect on whether or not a patient got better. Acute care surgery. Did they get decompressed in a timely way? Was their blood pressure adequately controlled? Were they given drugs like methylprednisolone or other drugs? And also the rehabilitation content and its intensity and when it got started and how long it was given and that sort of thing. Personal factors, motivation and effort. We all know that some patients will work harder than others. So personal factors will have an effect as well. And age. Now, I just turned 65. I don't bounce back as quickly as I did when I was 20 or 30. And we know that people who are older when they get hurt do not have the same likelihood of a good functional outcome as someone who's injured at age 25 or 30. Measurement variables. We also have to humbly admit that our current ability to measure with precision is not as good as it could be. So there's a huge effort underway to try to improve measurement variables, and there's also bias. If we measure in a way that allows the measurement takers who want patients to get better to know that the patient got the treatment, that could introduce a bias and could interfere with the interpretation of whether or not the patient got better. Okay. So the next question is, if the patient gets better, which of the variables were responsible? Which were the active ingredients? And this gets into the question of how do we distinguish cause and effect from association? So if a patient got better, was it because they were injured on Thursday? No, it was probably from something that was more plausibly a cause and effect variable. But how do you prove cause and effect? We have to narrow the focus on the experimental therapy. We're really interested in, was there an active ingredient in the therapy under investigation that was the reason they got better, or was it some of the other stuff? And the critical issue for scientists is eliminating bias. Everybody is hoping for improvement. The patients are hoping to get better. The treating folks, the clinicians, are desperately hoping that the patient gets better. Everybody's sort of rooting in the same direction here. So how do we eliminate bias? And it's through randomization. In other words, some of the patients got it, some of them didn't, and blinding, so that we don't let either the patient or the doctors know who got the therapy and who got not therapy. Okay? And that's not always easy. The gold standard, obviously, is a randomized placebo-controlled double-blind trial, but there are some ethical and practical constraints. So we can't always use placebos and blinding. It may not always be feasible, but the idea is some form of a trial that's designed to eliminate as much bias as you can. Okay? And we have to also acknowledge that a clinician's gestalt, in other words, what we think might happen, or patient testimonials are not sufficient. We can all go on a website and look up a clinic in Asia somewhere and find all sorts of testimonials of people that thought they were better after a trial and drew the connection back to the treatment they received, but this does not constitute scientific evidence. What does it take to get FDA approval? Well, you have to start with a preclinical animal model. It has to have some proof of concept. In other words, it looks like it works and it looks like it's reasonably safe. Then you go to human trials, and there are progressive phases. Phase 1 is open label, meaning patients all get the therapeutic intervention. There's no placebo, there's no randomization, no placebo. Usually it's about 10 or 15 patients, and it really is intended to look at feasibility, safety, and tolerability. Can it be done? Does it look reasonably safe? Phase 2 are usually where we start to see randomized controlled trials, 20 to 80 patients in one of these trials. And the questions that are being answered at that point is how to give it, what to give, what and how to measure, how to deliver it, what the dose is, the timing, the refinement of the primary outcome measures, what are we going to judge success, how are we going to judge success. So there's usually a series of these phase 2 trials that ultimately lead to the pivotal trial, phase 3. These are almost always multi-center. They have a rigorous protocol. They are usually enrolling hundreds of patients, and that means that many centers, like you folks here in Seattle and us in Denver, will be participating in trials of this type. We have a definitive protocol, and the FDA usually requires that there are going to be 2 successful trials that confirm each other before they'll say, okay, you can sell it, put it on the market. This takes 5 or more years and hundreds of millions of dollars in general. So it's not a process that's easy. And in fact, there is a great temptation to bypass this process because it is long and hard and expensive. I'm going to give you a couple of examples, just food for thought. Many of you may be familiar with Kevin Everett, who was injured in an NFL game in 2007, and he's had an excellent recovery. He comes out and does public interest spots periodically, and he received a therapy that was called modest systemic hypothermia. And this therapy was touted in the press as a miracle, that he had been given this therapy. He had been given chilled saline into his veins. Started actually in the stadium, and then he went on to have a good recovery. But the question then is, was this an association or was it cause and effect? What is the explanation? Why did he get so much better? He's not normal, by the way, at least as far as I can tell from seeing him on television, but he's had a very good recovery. Was it natural recovery? Was he actually a neurologically complete patient on the field, or was he an incomplete patient? Well, he couldn't do a thorough examination of the patient. He was on national television. And there's all sorts of other practical constraints. Was it the fact that he got an early decompression? He had very aggressive surgery to decompress the pressure on his spinal cord. We're now coming to appreciate that that may have an effect. But he was given some neuroprotective drugs, not commonly used anymore, but still plausible as a potential explanation, or was it the hypothermia treatment that he got? We don't really know. The University of Miami at the time was doing a phase 1 trial. They reported on 14 patients who were all neurologically complete at the start and came to the conclusion in their publications that it appeared reasonably safe. There were a few side effects. Any effective treatment is going to have potential for side effects. And that their conversion rate from Asia Impairment Scale A, as you can see, was 42.8%. Remember, I quoted you the big national databases say it's more like 20-25%. So this looked pretty good. In response, they have mounted a prospective observational trial, which means they're using it kind of as a standard of care, and they're just going to track patient outcomes. But they're not going to be doing a randomized controlled trial. There have been some problems. They tried to get some funding from the NIH to do this. There's a lot of back and forth. And the result is, right now, they're doing a prospective observational trial, which raises some questions. Will there ever be a randomized controlled trial to actually resolve this question? Should the therapy be a standard of care? Obviously, we have to balance the potential benefits and risks, but this is, as yet, an unanswered scientific question. Another example, the autologous macrophage trial. This was a cell therapy that we were involved with at Craig Hospital, and it was about 6 centers around the world where we were giving these cells that came from the patient. That's what autologous means. So the patients gave us the cells and we gave them back. We processed them in between, gave them back into the spinal cord. The animal model studies that have been performed in Israel as the backdrop for this trial looked encouraging. The phase 1 human trial, remember, open label, everybody got the treatment, no controls, not terribly scientific, was positive. And in fact, they had a conversion rate of 37.5%. Looked pretty impressive. And in fact, the 37.5 were patients who went from Asia A to Asia C, some motor incompleteness. Very tempting. So we mounted a phase 2 multi-center trial, and it was disappointing. The Asia conversion rate was 27% in the macrophage patients. Still looked like it was pretty reasonable. It looked like it was maybe a little bit better than the big databases would suggest, but in the control group, the conversion rate was almost 60%. This was unheard of. And the point here is not that the patients who were controls in this trial got such wonderful other therapy that that rate would have played out if we had enrolled 1,000 patients. This was probably a statistical anomaly. But it points out an important lesson, and that is that simply a small trial saying we had this many patients that converted, if it's not a controlled trial, you have to take that with a grain of salt. It's really a question of the strength, of the rigor of scientific evidence. Okay. Where are we today? Well, we've had a basic science explosive growth of knowledge. In cell-based therapies, that includes looking at initially fetal tissue, fetal cells, then we moved on to human embryonic stem cells. Then the next step was induced pluripotent cells that actually could use genetic reprogramming to take skin cells and turn them into embryonic stem cell-like cells. Still had some questions, however, about the safety and whatnot. So the next step was to learn how to reprogram skin cells directly into neurons without even passing through the pluripotent stage or the stem cell stage, if you will. So there's a lot of work going on in the preclinical animal model science. Translational science is also moving towards more clinical trials, expanding beyond acute to more chronic models, looking at ways to try to take some of the rigidity of those connections and free them up so that we could actually introduce some of these creative therapies into chronic patients. Increasing number of clinical trials underway that include drugs, cells, surgery, and rehabilitation. The handout, by the way, that you got is from the website scope-sci.org. It's on your handout. This is the Spinal Cord Outcomes Partnership Endeavor, which is a consortium, if you will, of academics, clinicians, research, regulatory agencies within the government and private industry that are all pulling together in the same direction to try to make this happen quicker. And the website produces a table that is the distillation of the hundreds of trials that are currently listed on clinicaltrials.gov, which is the big registry that all scientific trials would register on. And we distilled that down to the restorative trials, the trials that are loosely termed cure research. Okay? In addition, and I didn't put this in the table, there are a lot, probably just as many activity-based rehab trials that look at locomotor therapy, body weight supported treadmill training, upper extremity types of activities, complex motion simulators, etc., etc. The other thing that I think gives us much hope is if we look at the timeline of how these trials came online. There were a few trials, methylprednisolone back in the 80s and 90s. The Cygen trial that we've already told you, this is the biggest trial that was ever conducted, and the gacyclidine trial, the macrophage trial that we've already mentioned, the bioaxone-cephalin trial, this is the fampridine trial that we've already mentioned, the ATI-355, this is the anti-no-go protein trial that we've mentioned. So they were coming along at a slow but steady pace. The lithium trial, which also includes umbilical cord cells in China, the China SCI Net trial that we've talked about. And then we started to see more trials. The Giron trial, the minocycline trial on the University of Calgary, and all of a sudden, a huge number of trials. So what we're seeing is that the hard work of the preclinical translational scientists is bearing fruit. We're getting things into human trials, and that is very encouraging for the field. We're not there yet, but we're getting there. We also have to acknowledge that the rehab variable, that rehab activity-based therapies have entered the clinical mainstream and have been accepted as an important treatment in clinical practice, body weight supported treadmill training being the primary example. But we also have to humbly admit that we don't know yet enough about what it is about how we do this therapy that may make a difference. It's still somewhat of a black box. At the same time, the preclinical scientists that do the animal research have shown that there is a synergy between the biological treatments, cells as an example, stem cells, and rehabilitation intervention. Putting the hind limb of a rat on an exercycle, okay? The challenges for us as clinical scientists are how to incorporate this into clinical trial protocols. How much of what? Started when? For how long? And other difficult questions of how it's going to be funded, because this could be a very expensive component of a clinical trial. We've got a lot of bright people that are working on these challenges, but we still have a lot of unanswered questions today. I haven't even begun to talk about other technologies, functional electrical stimulation, the use of neural prostheses, brain-computer interfaces for the very high-level injuries, neuromodulation, trying to reset the gain, if you will, in the spinal cord to uncover some latent, unrealized function. I have also not talked about complementary and alternative approaches, acupuncture, chiropractic, vitamin-based therapies, low-power laser. Those of you that are frequenters of the internet or live in certain communities, Boulder, Santa Fe, know about this, and you've heard about it, but I think we have to accept that they would still have to stand the test of a scientific judgment. There's nothing magic about how to prove or answer a question with logic. And that's what we call science. Science, to me, is an impartial judge. And truly effective and safe therapies will and should stand that test. So that if any of these things are going to be proven effective, they ought to be put to a scientific test. By the way, at Craig, we got an NIH grant to study acupuncture. And we did a trial that enrolled about 40 patients. And it was a randomized control, sham-controlled trial, where we gave phony acupuncture to the control patients and real acupuncture to the treatment patients. We could not tell that there was a difference in the outcome. So there's also this fringe, medical tourism, less than quasi-science, human embryonic stem cells, fetal blue shark Schwann cells in Tijuana. If any of you want a trip to Tijuana, you could probably check into one of those clinics. Autologous Schwann cells in Ecuador, augmentum transposition in Cuba and China, other places, autologous bone marrow, umbilical cord blood. You'll notice that some of these interventions were also on the table as very rigorously studied. But the issue here is that these are not studies. They are for-profit, typically about $40,000 a pop, in that ballpark, very highly expensive, no scientific protocol, and they don't have any rigorous follow-up. So this is for-profit stem cell tourism, basically, or tourism clinics, and let the buyer beware. That's all I can say. Big questions. Is there any experimental therapy available that might make a difference? Well, today, if you're asking scientific proven therapy, the answer, unfortunately, is no. Where can we go to access experimental protocols? And by this, I do not mean going to a stem cell tourism clinic. I mean enrolling in a scientific experiment that will be rigorously controlled and well done. And the answer to that question is clinicaltrials.gov. And it's on the table here. And if you read the last couple of pages, it gives the website for clinicaltrials.gov. You can also go to the SCOPE website and get an update of this table, because we're updating it once a quarter. In fact, this table was just produced 7 days ago. So this is hot off the press. This is the current listing, if you will. Why am I not eligible? A lot of times patients will ask me, well, you know, I looked on the table and I'm not eligible. I'm a cervical patient and this trial is only enrolling thoracic. And that gets down to how sponsors design eligibility criteria. And we don't have time to go into the details, but it basically is the rough task of trying to make sure that it's safe and that we're eliminating some of the confounding variables that would hopefully allow the sponsor to determine whether or not it works and it's safe without going bankrupt in the process. This is a cold, hard reality, but that's why eligibility criteria are written. And they're not always the same. You can look at that table and see that they're all over the board. But not everybody is eligible for every trial. How can I make sure I will be a candidate? Well, I would say stay healthy. We've already heard a lot about that from previous speakers. It's to be as healthy as you can be. The last person that's going to get into an experimental protocol is somebody who's sick and a couch potato and not a go-getter. I mean, they're going to get kind of marginalized to the side. So be healthy. How can I put my name on the list? Is there a list? I can tell you probably not. But I can tell you what we do at Craig, and I suspect I do the same thing at University of Washington, is we have a database of all of you guys. And we call our database for matches to the eligibility criteria. And then we'll contact those people that seem to make sense, and we'll ask them if they want to participate in the trial. Can't science be more efficient? Can't we appoint a research czar that would just sort of cut to the chase, pick the most promising treatments, and stop funding all the other science? And the answer to that is, that would be bad. Science is a competition of ideas. And the best ideas will percolate to the top and will get the respect of the scientific community. And we're all biased. It took me a long time to confront my own biases about what I thought was going to work and what wasn't. And all I had to do was participate in a few trials that didn't go anywhere to make me realize that bias is a problem. And even a czar would be biased. So we don't want to give in to that. What do you think of the work being done in Beijing, Delhi? Should I go for it? Should you go to a stem cell clinic overseas? And my answer is, I'm not going to recommend it, but I'm not going to tell you can't go. And if you do go, by the way, please keep in touch. Because I would like to learn with you what happened. Not that I can somehow or other bend that or force that into a scientific analysis, but at least the base of knowledge will grow, even if it's a small increment. What have I got to lose? Well, the answer is we've all got something to lose, and I've seen patients that have gone to overseas clinic who have come back worse for wear. There is no such thing as a potent treatment that does not carry significant side effect. When will the cure be available? My statement is, in most of our lifetimes, we will have a treatment that comes out the other end of this process that improves function. Will it be simplistic and a cure like this injury had never happened? No. In fact, I think what's going to happen is we'll have the initial treatments will be modest in benefit, and that subsequent advances and refinements will build on that and eventually have true major impact. But initially, it's going to be modest. Whoops. So it's really the challenges of finding synergies and measuring benefits of all of these things. How can we do it better? Our preclinical colleagues need to develop more potent interventions. Right now, they're probably producing beneficial but modest. And that makes it difficult to find success. As clinicians, we need to be better at conducting clinical trials, more rigorous trial design and improving the outcome measurements, as we've said. And this is inevitably a translational dialogue. It's clinicians and laboratory researchers talking together, but also critically, it's you all and the rest of us, all of us together. So that patient input is critical to these interventions and these adventures that we're all on. So, final thought. Back to Ramoni Cajal, who won the Nobel Prize back in 1906. It is for the science of the future to change, if possible, this harsh decree. We are now in the era of clinical trials. And as I've shown, the timeline, this is really increasing in the last 10 years. And that's very gratifying. We need to develop a consensus standard of care, but this has not happened yet. And this has been elusive. There's been an exponential growth in knowledge. We've converted from a hopeless situation, and whether or not it would happen to when it will happen. It's when, in other words, not if. There is an urgency to travel this path without detours, to not get into blind alleys and false starts and that sort of thing. And this leads to a temptation to make shortcuts, but I would submit that that is actually going to lengthen the path and make it less efficient. Science, we need to let science work itself out. By applying these lessons learned, the path to our goal will be shortened, in my opinion. Thank you. Do we have time for questions? We have time for maybe one or two questions if somebody's got it. He's asking, what are the rehabilitation interventions that may have an effect? Right now, I'd say the prime example for that would be body weight supported treadmill training, especially for patients who are ASIA impairment scale C or D. In other words, have some motor sparing in their legs. In addition, there's some active work that's going on with functional electrical stimulation and neuromodulation. It was a list that I put on that's on the handout. What I would say is that we don't have firm scientific basis for saying what is the secret ingredient within those treatments. But there's enough evidence from the animal research side to tell us that this is going to be an important component in the big collective push to better recovery. Okay. If there's no other questions, we're done. Thank you all.